Good evening, everyone. I welcome you all for this series of thoracoscopy webinars conducted by the IAB. It is an IAB certification course. We are already to the 10th webinar, and after the last one, we'll be having physical workshops in 4 zones of India, which will be conducted in March and April. To complete your certification course, you have to attend one physical workshop apart from the webinars that you have attended. And I'm sure you have benefited a lot from the webinar till now. And keeping that spirit in mind, we are going to have today's talk, which is very important, is the role of cryobiopsy in thoracoscopy. Along with that, what is the role of surgeon? Now, surgeon is probably that support which we don't see. It is that oxygen that we breathe, but we don't care about. But I think here we focus on what the surgeon's role is in the management of pleural diseases, specifically in the role of thoracoscopy. So with no further wasting any more time, I think we'll start. So, yeah.
Yeah, hello everybody. We have a wonderful, charming young man, Dr. Mehul Tucker, with whom all of you know. Not only is he exuberant, energetic, but his work speaks for himself. He is known as the thoracoscopy man in Mumbai. His profile is there for all of you to see. D.Y. Patil Hospital, assistant professor. He's a teacher for DNB students and trainer for interventional bronchoscopy, director, Medansh Multi-Speciality Hospital, consultant pulmonologist, Jupiter Hospital, and soon to start his very state-of-the-art hospital. He's well-versed and is very balanced in his views. So thank you so much, Dr. Mehul Tucker, for taking up the onus of moderating this rather challenging session.
Thank you, sir. Thank you very much. And I look forward to your contribution for the same, sir. So let me introduce my first speaker. My first speaker is going to be Dr. Vishwanath Gella. He actually is a very senior consultant and he's a director of pulmonary medicine and sleep medicine at AIG Hospital, Hyderabad. He has been faculty at more than 50 conferences, has more than 16 publications, and is member of various societies. So he's going to speak on cryobiopsy in thoracoscopy, and we look forward to his talk. Dr. Vishwanath, please take over.
Very good evening, one and all. I hope I'm audible.
Yes, you are audible.
Yeah, just let me project my screen. Just. Is my PowerPoint visible?
Yes, we can see. Just put it in PowerPoint mode.
Yeah. So very good evening, one and all. And at the outset, I would like to thank the Indian Association of Bronchology and Dr. Amita Nena and Dr. Mehul for giving me this opportunity to share my thoughts on thoracoscopic cryobiopsy. And it has been very heartening to see the response of the younger colleagues for this thoracoscopic workshop. Before I give my talk, I would like to share that we do thoracoscopic cryobiopsy, but sparingly in very few patients. So I'm not here to propagate this technology. However, I'll tell you how to do, what is the evidence for this, and how do we utilize this for our benefit. We know that the cryobiopsy is playing a very important role in the management of interstitial lung diseases. And here, coming to the thoracoscopy, we all acknowledge that it has played a very important role in making a diagnosis of pleural conditions, especially tuberculosis and malignancy in our condition. We have two thoracoscopes, like a rigid thoracoscope and the semi-rigid thoracoscope. We know that rigid is mainly used for therapeutic purposes like editorialization and also for diagnostic purposes for obtaining biopsy. And coming to the semi-rigid thoracoscopy, mainly it is used for a diagnostic purpose for obtaining pleural biopsy. And it has been shown to have a very good sensitivity and specificity for diagnosis of pleural conditions. However, of late, the interventional pulmonologists have become slightly disheartened because of the smaller size of the tissue which is obtained with the flexi-rigid forceps. This happens because of the smaller size of the biopsy forceps cup, and also because of the slightly the forceps which is supplied with the thoracoscope is not stiff. As a result, sometimes it becomes frustrating to take a biopsy, especially from the thickened pleural wall. So in this condition, where you are not able to get a proper size pleural biopsy, cryobiopsy may help us in obtaining a larger tissue without crush artifacts. So today in our talk, we'll talk a little bit about the initial evidence for the thoracoscopic cryopleural biopsy, how it came into existence, and then the thoracoscopic cryobiopsy technique, what is the equipment which is needed for us, and a bit about the procedure step by step, and further evidence and role, whether do we have to use it in all the patients or where do we use it? Do we have any alternatives if you don't have an cryopleural biopsy? And some important practical points for our use. So coming to the initial evidence for the fluoroscopic cryobiopsy, the studies which were published in 2015 by Thomas et al. And Rosman et al. Have shown that when cryobiopsy was obtained, so the patients had a larger side tissue compared to the forceps biopsy. There were lesser crush artifacts and histology. When you use a forceps, because of the crush, actually, we have something called as crush artifacts. Generally, this interferes with the interpretation of the sample by a pathologist. So it was also seen that when cryoprobe biopsy was used, the full thickness pleural biopsy was obtained in more number of patients compared to the forceps biopsy. However, both the studies have shown that the diagnostic yield was similar, cryo versus the conventional forceps biopsy. And another small study which was done by PGI group showed that in a group of 6 patients, the diagnostic yield of cryobiopsy was 100%, whereas the yield of forceps biopsy was 70%, 75%. And again, in this study from PGI also, it was shown that the biopsy size was larger in size when cryoprobe was used, and also full thickness pleural biopsy was obtained in more proportion of patients. So having said this, so what is the equipment which we need to do a cryopleural biopsy? We require an RB cryo2 generator and a 1.7 mm cryoprobe. Till 2 years ago, we were getting 2.4 mm cryoprobe. However, 2.4 mm cryoprobe has been withdrawn from the market currently, and what we have available is 1.7 mm cryoprobe. The most studies which were done previously have used an 2.4 mm cryoprobe. We have another cryoprobe which is available, which is called as a mini cryoprobe, which comes with a diameter of 1.1 mm in diameter, and that is mainly used for taking biopsies from the peripheral lung lesions, that is the pulmonary nodules. So to pass this cryoprobe, we require a semi-rigid medical thoracoscope from Olympus, which is called as an LTF 160, which has a working channel of 2.8 mm diameter. So this is the RB cryo2 generator, which works with a carbon dioxide cryogen. And this is the entire trolley which contains the cryo generator and the carbon dioxide cylinder. And most of us know from the cryo lung biopsies that cryo works with an Joule-Thomson effect. So this is the cryoprobe which is used actually, which is a 1.7 mm cryoprobe, and it's passed through the flexi-rigid thoracoscopy, just similar to that of an forceps. So some practical tips when you pass the cryoprobe are make sure that you check whether the cryoprobe is working before using it in a patient or not. You insert in water and see whether it's forming an ice crystal or not. Lot of times we see that it fails when you go inside. So just make sure that it's working prior to using your cryoprobe, because sometimes the gas would have finished. You would not have noticed that before. So that is the reason why you need to do a practical check before you actually do a procedure. So I'll just show a brief video which highlights how we take cryopleural biopsies. Here we are passing the cryoprobe through the working channel of the semi-rigid thoracoscope. And when you're passing the cryoprobe through the working channel, make sure that the tip is very well visible beyond the tip of the flexi-rigid thoracoscope. Otherwise, you're likely to freeze the channel, working channel of the semi-rigid thoracoscope and cause damage to the semi-rigid thoracoscope. So make sure that this is well out. As you can see here, the tip is well out of the semi-rigid thoracoscope. So you are applying that on the pleura. In cryo lung biopsy, you ideally freeze for 4 to 5 seconds. Here you can use a larger freezing time. You can use up to 7 to 8 millimeters. And once you get a tissue, then the cryoprobe and the semi-rigid thoracoscope both are pulled out together. And then what you have seen there is the cryopleural biopsies are being thawed into normal saline actually. So you take the larger tissue biopsies, serial biopsies, 4 to 5 biopsies, and you thaw them into the saline. And then after that, this is transferred into the formalin within 5 to 10 minutes. Here, what is happening is the Joule-Thomson effect. When you are applying the tip of the cryoprobe to the pleura and activating it, the tip gets cooled intensely to a temperature of minus 60 to minus 80 degrees centigrade, and the tissues which are in touch with the cryoprobe tip gets frozen. And then when the probe and the thoracoscope are pulled together, the tissue that is adherent to the cryoprobe is also pulled out. As a result, you get larger tissues for analyzing. And mind you that this technique can be painful, especially when you're doing this procedure under local anesthesia and mild sedation actually. So Bangalore group from Narayana Hrudayalaya showed that if you can infiltrate the pleura using a transbronchial needle aspiration, keeping a needle with lignocaine in the area which you are going to take a biopsy, the pain was significantly lesser in patients in whom the pleura was infiltrated with the lignocaine. So this is going to be an important thing when you are going to do a pleural biopsy with a cryoprobe. So we have now seen that the safety and feasibility of cryoprobe through the thoracoscopes, especially the semi-rigid thoracoscopy, has been demonstrated in numerous studies. But the big question which has to be answered is it needed in every patient with a semi-rigid, when a patient is undergoing semi-rigid thoracoscopy, and is it superior to forceps? Because it's going to add cost to our procedure actually. Cryoprobes are costly and you need have a maintenance cost for the cylinder and the cryo generator servicing, and all this adds to the cost of the procedure. So to address this issue, I'll take you through some of the literature which has been published in the last 7 to 8 years. So in this study which was published in 2016, where they have compared the yield of rigid thoracoscopic biopsy, a cryopleural biopsy, and a flexi-rigid forceps biopsy, they have shown that a larger tissue was obtained when cryopleural biopsy was obtained compared to the flexi-rigid forceps biopsy. And obviously, always the rigid thoracoscopic biopsy fared better over other two groups in all the aspects, actually, whether it's a diagnostic yield, size of the specimen, or full thickness biopsy along with the subpleural fat. But when we compare the cryopleural biopsy versus the flexi-rigid forceps biopsy, the diagnostic yield was not similar to was not different between the cryo group and the flexi-rigid forceps group, even though the size of the biopsy was larger in the cryopleural biopsy. And again, in 2018, there was one more study, observational study from the Bangalore Narayana Hrudayalaya group, where they have again showed that the diagnostic yield was not different in the cryopleural biopsy group compared to the forceps group. And again, the PGI group have conducted the first randomized control trial where they compared the cryoprobe versus the forceps group in patients who are undergoing the semi-rigid thoracoscopy. In 50 patients, they have seen the results and they have shown that the diagnostic yield of cryopleural biopsy is again not different from the flexible forceps biopsy. It was 78% and 76%, which was not statistically significant difference actually, though the sample size was larger in the cryopleural biopsy group. So based on all the accumulated evidence, in 2020 and 2022, there were large meta-analysis which looked at the utility of the cryopleural biopsy. Both the meta-analysis have shown that the size of the biopsy which is obtained by the pleural biopsy is larger in the cryo group. The artifacts are much lesser in the cryo group, and full thickness biopsy was obtained in more proportion of patients in the cryo group. However, the diagnostic yield did not differ between both the groups. So the inference was that the cryobiopsy samples are larger and without crush artifacts. Diagnostic yield did not differ between the forceps group and cryobiopsy group. So before we end our talk, actually, I would like to share some of the practical points for using a cryoprobe. When you have a rigid thoracoscope, there is no additional utility of having a cryoprobe actually. But when you have a semi-rigid thoracoscope, and when you think that pleura is hard and thickened with lot of plaque-like lesion, cryobiopsy may help in obtaining deeper tissue specimens and a larger samples. In most cases, the forceps which is obtained and which is supplied with the semi-rigid thoracoscopy will be able to get good tissue biopsies sufficient enough for making a histopathological diagnosis, AFB cultures, and the gene expert. However, when you feel that these kind of thickened pleural lesions are there, this is where the cryoprobe may help in obtaining deeper specimens. But mind you, in certain subset of patients, it can lead to increased risk of bleeding. That is in patients who have underlying platelet dysfunction, coagulopathy, and patients who are on antiplatelets. And I also told you about the utility of using lignocaine infiltration, especially when you're planning to do it in a patient who is under mild sedation or under local anesthesia. So as I told you, cryobiopsy gives us a larger samples for histopathology without crush artifacts. It is not known whether this larger specimen might have a better yield, especially when you're trying to do multiple samples like immunohistochemistry, PDL1, and molecular markers like EGFR, ALK1, and a lot of other things. In oncology, we see that every year there is one more marker which is added into the armamentarium. So that has not been ideally studied, but if you really want to get a larger sample enough for doing all these tests, maybe cryopleural biopsy might be able to give us a larger specimen for all these patients. The current evidence says that there is no difference in the diagnostic yield to make a diagnosis between the forceps biopsy and the cryopleural biopsy, and the same has been reflected in the two meta-analyses which have been published in 2020 and in 2022. And if you still if you have a semi-rigid thoracoscopy and you're not happy with your forceps which is supplied with the semi-rigid thoracoscope, and you really want to have alternative, you can use some of the forceps which are there in the gastroenterology armamentarium. Actually, this is one thing which we use actually. This is called as an radial jaw 4. This comes from Boston Scientific. And then this goes through the working channel of a semi-rigid thoracoscope, which has a 2.8 mm working channel. As you can see that the jaws are 2.8 mm in diameter. So this actually gives us a very good tissue. This is very stiff in the pleural cavity. It doesn't hang like the regular forceps which we get, sometimes which becomes frustrating to the interventional pulmonologists. So this is what we use. So I think, so you can use this cryoprobe selectively in some cases if you already have it to get a larger tissue for obtaining different oncological markers, and also if you have a thick plaque-like lesions which is difficult to biopsy with a regular forceps. In those kind of things, actually your cryopleural biopsy is going to definitely help you. And then if you don't have any other alternative, you don't have a cryoprobe, these are some of the things which you can use it for your patient. And thank you all for patient listening and for the opportunity given. We can have questions now or at the...
No, I think we'll have the questions in the end because we'll have a lot of questions to ask you. We are not going to let you go away so soon.
Next results.
So thank you, Dr. Vishwanath, for giving us a very good overview of what is a cryoprobe, how do we use it, and not only that, telling us what else can you use if you don't have a cryoprobe. That was a smart move in the end. And actually, the fact that the smaller 1.1 mm probe can be used for lung and the 1.7 from the pleura. All this information these are the points that we want to get across to the people who are listening to you. And excellent talk, I would say. Now, moving on, like whenever we are in trouble, the person that we call our supermen are surgeons. So it is my great honor to have my next speaker, who is a well-known cardiothoracic surgeon. Actually, he needs no introduction, Dr. Nasir Yusuf. He is been trained in UK and Ireland. He has been doing VATS in mediastinoscopy since 1999. And his areas of interest are surgery in MDR and XDR, tuberculosis, lung cancer, lung volume reduction surgeries. And his expertise ranges from operating on a 5-day-old baby to a 105-year-old man. He was probably the first person to have live thoracoscopy workshop in NAPCON 2010. He has operated on post-COVID lung sequelae surgery in India. He has given multiple orations. He is the South Zone chairman of NCCP DES, and he's the organizing chairman for our upcoming BronchoCon 2024. He has organized workshops in NAPCON earlier. He's been awarded with Vijay Shri Award, IIM-TAI Innovative Surgeries from the government of Kerala, sorry, and he has more than 22 publications, and he practices in Calicut and Kochi. Sir, I hand over the stage to you, sir, and please enlighten us on the surgeon's role beyond the medical frontiers.
Thank you so much, Dr. Mel Tucker. It was nice to hear those lovely words of yours. And incidentally, Mel himself is a fantastic stand-up comedian. You've got to, I wish he had his own YouTube channel. He's excellent at it.
Thank you, sir.
Anyhow, how about delving into the intricacies of pulmonology, bronchology, interventional pulmonology as well, while savoring the spices of and exotic spices of Wayanad and Kerala in the lush green paradise of God's own country, casting nets of innovation. So welcome to BronchoCon Cochin 2024. Don't forget 24, 25, and 26 of May. I promise you that will be a memorable experience in your life. Well, the conflict between the pulmonologist, more specifically interventional pulmonologist, and telescoping down to those maverick pulmonologists and the thoracic surgeon has always and will always be a question and test of times. Briefly, you have all been in the last few weeks, excellent webinars. You're all, in fact, bombarded with so much of literature. I shall not burden you further with evidence-based, evidence-burdened medicine. So it shall keep you away from all those papers. You're already aware of it. We'll probably take you through visuals, which will be more pleasing to your eye, and just sit back and relax. Diagnostic thoracoscopy, pleural effusions, undiagnosed, as earlier said by Dr. Gella, excellent talk, exposition. The forceps biopsy is the best. And of course, in undiagnosed effusions, tuberculosis, malignancy, and at times to evaluate chest trauma. Period. What goes beyond, we shall discuss in the next few minutes. And that's for you to decide how much and how far will you go. Therapeutic, pleural disease, malignancy, recurrent pleural effusion, no recurrent pneumothorax, debatable. Adhesiolysis of flimsy adhesions, again, there's no contention about it. And of course, leave in the pleural toilet in fibrillopulmonary stages of empyema, TP and DNAs, that definitely can be a role. This is the most important slide of this talk. This has been various American College of Chest Physicians, British Thoracic Society, the green zone, go, pleuroscopy, inspect the pleura, do the pleural biopsies of the parietal pleura, pleurodesis. Next enters the gray area, pneumothorax, empyema, stage 1, no issues. Lung biopsy, again questionable, and don't go to that red zone, pink zone, touching and playing with the lung, pericardium, etc., etc. Pleural effusion, I'll take you through a small video of an unusual diagnosis, clear fluid. And you see the pleura, kind of small nodules. And this is classical of entire thing. You don't see any normal pleura at all. And see the water. It was like water, the fluid was a mesothelioma. And look further down at the diaphragm. There's another patient we have conjoined the two. You see coarse appearance of nodules, flimsy adhesions that you could possibly deal with. And this is more sinister. This is again mesothelioma, very sinister. Forceps rigid biopsy will set the diagnosis at rest. Now, you've seen effusions, clear cut. Let's go on to I shall be fast forwarding into areas of where gray areas will be debatable. Stage 1, exudative, swelling of pleural membranes, fibrin clear yellow fluid, corresponds to uncomplicated pleural effusion. It's all yours. Stage 2, where you have heavy fibrin deposits. Stage 2 is a gray zone. It's a little more complicated. And there your expertise and skill and decision comes into play. The third, keep away, organized empyema with ingrowth of fibroblasts. The fibrothorax, I would suggest keep well away from there. And this is a case of empyema. And as you can see, we are inside the lung, and you see a hole at the center. That's the bronchopleural fistula. We instill water to identify the leak, ask our friends across, and they ambu, and you can see bubbling. This is not it's wishful thinking that will disappear with conservative management. This needs actual physical presence inside the pleural cavity, inside the lung. And going further into empyema, you've seen the simple adhesions that you can deal with. This gets more complicated. You can see there's getting organized. There are adhesions, loculations, which you can break. And what happens is, in such a patient, if you do thoracoscopy, medical thoracoscopy, they marginally improve. The X-ray shows improvement, but a CT scan, which is very critical, that will only show how much residual pathology is left behind. This needs actual clearance. And further, if the lung is trapped, yes, I'll be talking over this video. The lung is trapped with a peel around it. This needs to be crisscrossed, opened, and it's trapped lung. You got to take it off. Very gently take it off millimeter by millimeter off the lung. And it takes about 3 to 4 hours, and a lot of meticulous effort is required to prevent air leak. And once air leak comes in, it is the bane of the patient as well as the surgeon. Now you can see it blooming out like a lotus, and thereafter the lung expands and fills the pleural cavity, reaching up to the pleural surface. And that's what is required in a decortication. And this is done in a manner that you release not only the apex, but also the diaphragm, as well as the mediastinal aspect. So it's 300 all around the lung expands. And so important the diaphragm should be released because, as you know, 80% of breathing is contributed by the diaphragm. So the diaphragmatic contour has to be regained. Now, lung biopsies, again, we have people doing lung biopsies, cryo, as mentioned earlier. So this was a patient with ILD, but important I would like you to note is that worm-like structure. We went in for ILD lung biopsy, and when we biopsied that specimen, at that point, this is about 20 years back, we were doing forceps lung direct biopsy. Those days, taper had not come in, and directly used to do it. And this is what they say, that you could also possibly do it. But here, if there's a complication of a leak or bleed, we can deal with it. We normally cauterize and come off. I wouldn't recommend this. I no longer do it. What we do now is much more, I would say, pleasing to the eye, sane, and using staplers. This is just to show you the how the lung looks like it, and the pleura as well. That's the oblique fissure you see here. That's the rigid trocar and the cannula coming in. Further down, you can see the diaphragm now coming up. It's also pristine. And further, the middle lobe, the fissures. The lung is normally very smooth. It's difficult to grasp. So it keeps slipping. I'm deliberately showing this to show that, it is a slippery customer. Pick it up, then use a stapler, and you can take multiple biopsies all over in about 15 minutes. So in fact, when we do lung biopsies, we take from all three lobes and the area which is most, the pathology appears to be quite significant. Fire a stapler and done. Similarly, solitary pulmonary nodules can be dealt with by using the stapler. And then we come to another gray area of pneumothorax. In secondary spontaneous pneumothorax, preferably if you have a thoracic surgeon, get them involved so they know right from the beginning what's happening. A persistent air leak of the lung, failure for it to re-expand in 3 to 5 days, start thinking about some other option, and a maximum drainage of 15 days. These small adhesions you can deal with. Sometimes adhesions themselves hold the lung back from expanding and filling up the chest wall space in the pleural cavity. So here, such adhesions can be dealt with by the pulmonologist easily. So how do these blebs, or how does the pneumothorax appear? It's due to subpleural blebs and bullae, or rupture of them. Usually they are in the apex, and when they rupture, the blebs, the small tiny blebs, they cause this kind of air leak. This kind of alveolar leak would seal off in about 7 to 14 days without further ado. The blebs at the apex, multiple blebs, it's a different cup of tea. And so what we say as surgeons, and for the patient, a second ipsilateral pneumothorax surgical opinion should be taken. First contralateral pneumothorax, synchronous bilateral spontaneous pneumothorax, persistent air leak, spontaneous hemothorax at times, and those professionals at risk, like pilots and divers, and of course, pregnancy, please consider a surgical opinion. And how do we deal with it? Surgical repair of the persistent air leak and the prevention of recurrence. That's very important. And how do we prevent recurrence? Is by doing a pleurectomy, and some surgeons follow it up with tau pleurodesis. It could be done through thoracotomy or through VATS. Recurrence rate is almost negligible. Pneumothorax, I wonder. So that was a large bullae. Well, I shall show you that in a minute. So we deal with blebectomy, bullectomy, decortication, as you've seen, closure of BPF, and resection of emphysematous areas and porous segments. That's getting into lung volume reduction surgery. And this is the earlier X-ray, which seemed to be like a pneumothorax. No, it was a bulla. And as we go in, I hope the video plays. Yes, we are in luck. You can see that it was not a pneumothorax, it was a bulla. And this, fortunately, is one of the easier bullae. If there could be adhesions, release them. You get a nice base, pick up the base, and fire staplers. Maybe you'll require 1 or 2 staplers, similar to how we do a lung biopsy. And this is beautifully seen in this patient. There was a tag left behind, which required a second firing. And you can see a nice, smooth line of pins. And that's how the large bullae appear in vitro. This is followed up with pleurectomy. What you do as a pleural biopsy, where you take a pinch, peel, or a lateral swipe, and you take layers and layers of pleura out, which leaves a very raw surface inside. And you can imagine anything which the lung gets up to the chest wall, very important for the lung to get up the chest wall, then because of the very inflammatory process, it gets stuck and adherent. Now, this is something which can happen even in the hands of surgeons. This was in my initial days, not that it cannot happen even now. We went in a pristine lung, undiagnosed effusion, to take a pleural biopsy. The classical teaching, take the biopsy from the upper end of the rib, the pleural biopsy. So you're well away from the intercostal vessels. So keeping all that in mind, you see there's absolutely no lesion. We went into biopsies, multiple biopsies. The first time round, it was a pinch biopsy, no problem. And then see what happens. This is safe. And now we have to take multiple pinch biopsies, take it and do a lateral sweep, as you saw while doing a pleurectomy. And there, what happens is, there you can see spontaneous bleeding happening. In this, it was an intercostal artery, no panic situation. Use the cuff forceps as a cautery, and you can deal with it. And even better, today is we have the suction cautery. This helps in dealing with these kind of bleeds. A quick look at this is a very unusual thing, turned out to be sarcoid of the pleura. And this was quite frightening. It had hemorrhagic effusion. We were expecting malignancy, but this turned out to be both on the surface of the lung as well as in the parietal pleura. Awful looking. It turned out to be a malignant epithelioid hemangioendothelioma. Massive effusion, well tapped, and this is what was found. It turned out to be chylothorax. Very easy to diagnose, but most disheartening. High triglycerides, cholesterol levels, and are also elevated in the fluid. Didn't respond to conservative treatment. We had to go in and ligate the thoracic duct, which is seen here, which is quite pristine in this case, but normally hard to find. You find it is usually identified between the aorta, esophagus, and the zygos vein. Once ligated, within 24 to 48 hours, the patient gets it. Remarkably, the effusion comes down. You can use, we talked about earlier about EBUS, I'm sure in one of those sessions before, you must have heard approaching lymph nodes. A thoracic surgeon can use VATS and mediastinal to reach all lymph nodes. And here you see a left hilar mass, a left hilar lymph node, and a lesion here. I hope this plays, but you can well imagine we have to reach the mediastinal pleura and take biopsies, and it can be easily done. Again, important to know your anatomy and identify the structures. Sympathectomy can be done, again, not too difficult, done by even interventional pulmonologists today, the maverick surgeons, the pulmonologists who wanted to be surgeons. And then further on, even posterior mediastinal masses, small lesions can be accessed. This is for you for posterity. This is a patient with COVID lung. I know it's not really pertaining to our talk today. Throwing multiple pneumothoraces in the ICU, we passed a scope, and this was end stage COVID lung, like it has become gray hepatization. And the last, very guess you guys know what's happening. You have the lung here. This is the heart, quite tense. Supposed to be beating, right? But it isn't beating. Obviously, it is tense because of underlying cardiac tamponade pericardial effusion. Use the needle to poke into it, and then you see this fountain of blood coming in. Even surgeons miss a heartbeat here because you're not sure if it's gone to the RV or LV. But the color of the fluid and the patient remaining stable, in fact, improving, knew we were at the right spot. In addition to in addition to letting off the fluid, what we can do in this case is also, you can see that there's effusion around the heart as well as effusion, pleural effusions. Anyway, so you could do a pericardial biopsy as well, make a window and drain the fluid. It enters into the pleural cavity, and thereafter, the pleural cavity being a large space, absorption is quite rapid. So coming to the first and last slide again, first and last, go, in the green area, fluoroscopy, pleural biopsy, fluoridesis, great. Gray zone, adhesions, small blebs, you can do fluoroscopy and deal with it. But empyema stage 1 is fine. Forceps, again, you have to be careful. Basically, if you stick to the green zone, you're okay. With years of experience, you can venture into the gray zone, but I would say keep the red zone away from you. So undiagnosed effusions, pleuroadhesiolysis, pleural biopsy, pleurodesis, empyema stage 1, great, nothing to worry. Patient sleeps well, you're fine, and it's always better to be safe than sorry. So this is, to a hammer, everything appears a nail. One must not be a cowboy just because he has a thoracoscope, an instrument shooting from his hips. Please, gentlemen and ladies, be empathetic and compassionate to your patients, because tomorrow it could be you. So would you like to be a guinea pig in the hands of a greenhorn or be in skilled and safe care? It's all up to you. Imagine yourself as a patient and how would you do it? And as a professor's wife of mine said in one of those felicitation dinners, I would not like to be a mere statistic or a footnote in the chapter of thoracoscopy. So please confine yourself in the green zone, years of experience, go on to the second stage maybe, but third stage, for your safety, for the patient's safety, please refrain. Leave it to the surgeons, as Hippocrates said, leave the stone to the masons, leave it to the experts. God cannot be everywhere, so he sent doctors like you, pulmonologists like you, with excellence and selflessness. Thank you very much. Can you hear me? I think I've finished.
Yes, sir. Dr. Mehul, sir? Dr. Mehul?
Yeah, he should be back in a moment. So basically, to fill in the gap, this is not to put down anybody, but just to be, one thing more, you have to do new things, then only can you make progress. So just be a little cautious while progressing with things. Any questions or till Mehul joins us? Thoracoscopy, Amol, would you like to add something or say something to just till Mehul comes back?
Hi, good evening, sir. Good evening, everyone. So, sir, excellent talk, first of all. Lovely videos. So, yes, I completely agree with you that as intervention pulmonologists, staying in the stage 1 is safe for you as well as the patient. With some experience, you can go up to few things in the gray zone, but then things beyond that, it's always safer to have your surgeon friend along.
Hi, can you guys hear me?
Yeah, thank
Hi,
you.
Mehul, good evening.
Yeah, extremely sorry. My network played a trick on me. And I'm so sorry. Nasir sir, I have no words. I mean, actually, we look up to you when we are in trouble and looking at the talk and looking what you can do. I'm sure I would like to stick in the green zone and not even venture near the red zone. And there are many questions already coming in the chat box. So I'm hoping that you stick around for answer that. So your grasp on medical knowledge and the grasp on English is so eloquent. I thought of, sometimes we joke about, but I'm sure Mr. Sashi Tharoor will also be ashamed when he will speak to you. Your grasp on English language is excellent, sir. Excellent talk, sir. Now let's get in all our panelists into the foray. I will, yeah. So here you can see we have three eminent panelists today with us. First, I would like to introduce Dr. Jayaraman. He's a senior consultant pulmonologist. He works in MGM Healthcare, Bill Roth, and Apollo First Med Hospitals, Chennai. He has his own chest and sleep clinic in Chennai. He has a special interest in interventional pulmonology, sleep disordered breathing, and is a chairman academic committee of Indian Medical Association in Tamil Nadu State Branch. Welcome, sir. Welcome to the panel.
Good evening. Thank you, sir.
And we have next with us Dr. Bajpai. Dr. Jyoti Bajpai is an assistant professor in the Department of Respiratory Medicines. Look at the number of publications. She has more than 75 publications. She has more than 6 research projects undertaken. She has won the Woman Physician of the Year award. She is a member of many national and international bodies. She has a special work field in the airway disorders, ILD, tuberculosis, pulmonary vascular disease, and interventional pulmonology. And she has delivered talks in more than 40 national and international conferences. I welcome Dr. Jyoti. And next we have with us my good friend Dr. Amol Bhanushali. He's like, since we to balance out, we needed a surgeon, and the physician should not feel that it is all their domain. So we got a surgeon into the panel. Dr. Amol Bhanushali is the medical director at Dr. Bhanushali's Hospital and Center for Lung Surgery in Thane in Maharashtra. He's a consultant thoracic surgeon at multiple corporate hospitals here in Hinduja Hospital, Leelavati Hospital, Kaushalya Hospital. He's an honorary thoracic surgeon at the Sivri TB Hospital, the biggest TB hospital in Asia, and is a faculty of thoracoscopy and INVATS courses, which are happening in Mumbai. I welcome Dr. Amol. Dr. Amol, can you hear me?
Yes, I can. Thanks, Mehul.
Hello? Am I
Yeah.
audible?
Am I audible?
Yeah. Sorry. My network is suddenly acting
Yeah.
wonky. Yeah. So I'll start with the
That's it.
panel discussion.
Yes,
And
thanks,
the
Mehul.
first question. First question comes to you, Dr. Amol. As a surgeon, now we have listened to, we have heard the speakers on what they do as a surgical practice. We have heard on cryobiopsies, and up till now in this webinars, we have heard about the medical side of the story. Now we need to hear the surgical side. So as a surgeon, what are the common illnesses where a surgical consult is sought with regards to pleural disorders?
It starts from usually complex or loculated pleural effusions, then empymas, usually stage 2 and stage 3 empymas, and also for decortications for pleural thickening, which is seen on CT scan or PET scan, especially with an uptake on PET scan. So these are the three most common pleural diseases where a surgical consult is sought. And also to complete the list, at times also for loculated pneumothorax or a loculated hydropneumothorax.
Okay. So, these are the one common places where you get a consult for this
Yes.
thing. So, as far as pleural disorders are concerned, I agree with you. We also, as a physician, if I want a surgical consult, I would see any complex pleural disease, I would stay away from them. As Dr. Nasir said, stay in the green zone. Anything else, I would refer to a surgeon. Now, let's take one disease at a time so that we understand in the panel discussion that what do we do in each of the disorders. So first, coming to you, Dr. Jayaraman, from a physician's perspective, let's say you're dealing with an empyema. What is the ideal time for a thoracic intervention by a physician or a pulmonologist? And what kind of interventions would you like to do?
Thank you, Dr. Mehul. First of all, I thank you, IAB and Amita ma'am, for this wonderful opportunity to present my expert opinion here. Very good evening to everyone. Just now, Dr. Nasir sir presented beautifully about the role of pulmonologists in a case of thoracoscopic interventions. So coming to the question, Dr. Mehul, so the question is, so when will you intervene in a case of empyema? So there are empyema, we all know very well about that. There are three stages empyema. One is the exudative stage, other one is the fibrinopurulent stage, other one is the organizing stage. So in a case of first stage, so usually in a mild to moderate pyothorax cases, so we can do the diagnostic fluorescences. If first present, we start the antibiotic empirically, and once the report comes, we can de-escalate in a stage 1 empyema in a mild cases of pyothorax. If it is a moderate pus inside, we can do the tube thoracostomy. As a pulmonologist, we do the intercostal drainage and remove all the pus from the pleural cavity and continue the antibiotic. In a case of stage 2, that is a fibrinopurulent stage, if the patients come to the second stage, fibrinopurulent, to our pulmonology department, in the early phase of fibrinopurulent stage, slowly the early loculated, the fluid now will form thick fluid and fibrin formation, and the mild loculations is going to form. That stage also our interventional pulmonologist plays in this, and we do the thoracoscopy, mainly the rigid thoracoscopy, and break all the locules. We can do the adhesive lysis. So Nasir sir said this is a gray area. So early phase of stage 2, fibrinopurulent stage, we can do that adhesive lysis and the complete drainage of the pus from the pleural cavity and place the ICD. So this is the one. Stage 2 and 3, so entirely up to the VATS, that is the thoracic surgeon role only. So in the stage 2, early stage of fibrinopurulent, and stage 1 of exudative phase, so we can do our role as drainage by thoracentesis and tube thoracostomy and rigid thoracoscopy or flexible thoracoscopy, adhesive lysis, etc., and placement of the ICD. So this way we proceed in the empyema.
Thank you, Dr. Jaraman. So basically, if you can deal with stage 2 complications of bleeding, if you see a vascularized adhesion, you may not want to touch it, because if the bleeding causes your blood pressure to go low, you should not be touching that. That is the dictum I follow. This is not my area. So where you can intervene is stage 1. Unfortunately, most of the patients don't come to us, a pulmonologist, in stage 1. So many a times we are left with no choice but to refer to a surgeon. But yes, if you have been good with your thoracoscope, if you have a rigid thoracoscope, as you rightly said, we can go ahead and do some intervention and place the ICD, which is very important. Coming to you, Dr. Jyoti, which of the cases would you directly refer to a surgeon? Like Dr. Jaraman mentioned about few cases where, I'm talking with regards to pleural empyema only, where you would directly want to straight away say, okay, this case needs to be handled by a surgeon and I should not be touching it.
Thank you, Mohil, for asking these beautiful questions to me. First of all, I tell you that empyema can be divided in two causes, like traumatic and non-traumatic. Traumatic empyema also seen with esophageal rupture. If there is a esophageal rupture, it can cause empyema. Then I don't want to touch this patient, and I would directly refer to this patient to surgeon. Second one is traumatic pneumothorax, and any case of road traffic accident. These kind of cases come with us, any pneumothorax and empyematosis, then directly refer to surgeon. So first of all, traumatic cases. Then second one, the empyema cases, which those who are not responding to antibiotics, intercostal tube drainage, or intrapleural fibrinolytic therapy also. So after this, we have to refer these patients directly to the surgeon. And another one most important thing, some mediastinal empyema is also see in our OPD regularly. So I think these cases are also referred to the surgeon for the further management. And some rupture of hydrated cyst and rupture of mediastinal cyst, these cases are also directly referred to the surgeon. So, and if we get, as already told by everybody, if grade 3 or class 3 empyema is there and fibrothorax is there and CT scan suggestive of there is a thickening of pleura, calcification, and we are not able to drain this empyema, so we have to refer these cases to the surgeon in the case of empyema.
Excellent, excellent. In fact, if you see rib crowding in a case of empyema, don't even put an ICD. Straight away refer to the surgeon, and I'm sure
Yes.
surgeon will be directly happy to deal with such a case. So now
One more thing is sometimes
yeah.
the patient came within our, we belong to Lucknow area, so there is a lot of village area. India is a country of villages. So most of the patient came with us like 1 month, 2 month ICD in situ and intercostal treatment, and there is a destroyed lung. There is a no lung parenchyma. So I think these cases are already referred to the surgeon, and there is a no role of doing like medical thoracoscopy and all, because there are a lot of adhesions and crowding are also there. So these cases also refer to the surgeon immediately.
Yeah, as you rightly said, like even I studied in Jaipur, so we used to get a lot of patients from the periphery to the hospital. And there again, if you have a case been basically more than 2 weeks of any pleural disease is not your area to touch. Most likely you won't be able to benefit the patient. Now, we've heard from the physician's perspective. Now, let's come to the surgeon, Dr. Amol. From a surgeon's perspective, physicians told you, okay, we would see these criteria and then refer to the patient. From the surgeon's perspective, when would you want ideally the patient to come to you so that it is not a difficult case, because even surgeons have to make sure that they do the complete job. So, from a surgeon's perspective, when would you want to intervene? And whether you would prefer to do VATS or an open case in any such cases?
So usually empymas which are referred within the first 3 months, I would never directly open. In fact, nowadays hardly any cases I would directly open unless it is like a very, very crowded. There is a lot of rib crowding, or it is impossible to get into the chest by VATS. Only then I would directly open. But we usually put in a scope for almost all empymas now. The criteria for taking up these patients for surgery is, I would say that on sonography, when you have the report saying multiloculated effusion or septations or pleural thickening, that those are the patients which I think should need an intervention. And also, when you do a CT scan and you see pleural thickening, you see a trapped lung, or you see, multiple loculations, like multiloculated, then these are the patients which I would take up for VATS directly.
Okay, so you say the earlier the better. In fact, there is more and more evidence coming up that if you intervene early in a pleural empyema, probably you might get a better result. So pus anywhere needs to be drained. So either it is by the physician or by the surgeon. And before you put an ICD, like if a physician is there and putting an ICD and I see it is difficult, it is not draining, I would give the consult the next day if this patient needs a VAT surgery or at least a thoracic intervention.
Yes.
So the earlier the better. And as you rightly said, if you have a complicated empyema, as Dr. Jyoti was saying, these patients do deserve to go to a surgeon. But as Dr. Nasir was saying, there are some maverick physicians who do intervene in such cases. So, Dr. Wish, physicians who do a lot of interventions, would you intervene in grade 2 or maybe early grade 3 empyema by putting in a second port or something? Dr. Vishwanath?
Oh, sorry.
Hi. So, I mean, since you do a lot of interventions, would you intervene in any such great gray areas where you would, maybe do a thoracoscopy or put in a second port and try to do some adhesiolysis or something? Or would you still refer to a surgeon?
In my practice, actually, I stick to taking pleural biopsies and mild adhesiolysis in grade 1, actually. We have tried that in a couple of patients, but maybe I think it requires especially more practice to put 2 ports and then work like surgeons, actually. If you have a surgeon friend who is working along with you or a person who is already trained, that becomes simpler for you to understand the orientation and everything. But I generally stick to only 1 port in my practice.
Okay, good. Good to hear that. So I think all the panelists up till now have agreed that if it is grade 1 and early grade 2 empymas, maybe you can do some intervention as a physician, but put in an ICD if required, do a thoracoscopy and do some adhesiolysis if you have a rigid thoracoscope. But if you don't have a rigid thoracoscope, or maybe it is grade 2, grade 3, it is a surgeon's domain. But coming to the surgeon, Nasir sir, are you around, sir? Are there any cases where you would actually say, no, I would not want to do a thoracoscopy or a VATS in such a case? This patient doesn't deserve VATS.
Thank you for that very thoughtful question. Mel is a wonderful stand-up comedian. I forgot to mention that. I've seen him perform. It's fantastic. It's very clear in my mind. In fact, all of us should be grateful to, including the delegates, the participants, to the Indian Association for Bronchology for conducting this marvelous series. Amazing number of responses. Dr. R.P. Meena, Dr. Amita Nene, the entire thing. Dr. Mehul is the treasurer. Absolutely great. Just getting carried away with your performance and results. And coming back to your question, now again, see a surgeon's perspective and the pulmonologist. It's like to a hammer, everything appears as a nail. So the only times when we don't do is first is there are some contraindications, like the patient is very morbid. And we do remember that we do it under general anesthesia. So that has its own set of risks. Poor ejection fraction, bleeding disorders, liver failure, kidney failure. These are areas which we have to be very careful and avoid anesthesia, in fact, do some palliative procedure. So what we say is American Society of Anesthesiologists have a very good system of grading, ASA 1, 2, 3, 4, 5. Anything which comes in remember, these are all septic cases. It's a focus of infection there. So there would be septicemia, the counts would be high, CRP would be high, and diabetic. You have to be very careful in such cases. But again, this is the second point I'm coming to. It depends on how you counsel the patient. So that's where it comes to the pulmonologist first. And usually, with due respect to them, depends on how the pulmonologist counsel them. And they say, oh, they're not willing for surgery. So the area would be comorbidities is one place, or the patient refuses. By God, for heaven's sake, do not put a knife on me. These are the areas where we keep away, but counseling is so important as well. But remember, again, we get a large chunk of our patients, I'm sure Amol also gets in, when after a procedure, say a thoracoscopy, the patient comes back. Initially, they are very happy. There's some palliative effect. They come back with continuing pain or crowded ribs, disfigurement. So I'm not as perfect as I used to be. So can you do something? And along with this decortication, this crowding of ribs can all be got back to normal. What we do is a pleurectomy. That's so important. The 5 steps, not only do a decortication, not only break the loculations, not only drain the fluid, get the whole lung moving, but do a pleurectomy as well, which brings back the entire contour of the chest wall back to normal.
I agree, sir. Sometimes counseling plays a big role. I mean, just reminded me of a case of a 71-year-old gentleman with an empyema. He was a CKD patient on dialysis and an ejection fraction of 35. Now, what do? There is an ICD, it is not draining. So the counseling helped. Well, I spoke to my surgeon whether you can operate. He said, I can if you give me fitness. I said, okay, I'll speak to the rest of the guys. I spoke to the cardiologist, the nephrologist, and everybody as a team decided, okay, this is a high risk, but can be done. And it went well. The surgeon operated. We took care of the patient. Patient is now doing fine. So it also depends on us whether we show confidence in our surgeons to operate. But yes, there are some cases which are very difficult and probably you need to wait or avoid in such cases. So
Mehul, if you're
coming
okay,
back to
can I say something here?
Yeah.
So these high-risk patients, Mehul, we also have done few cases under only pure thoracic epidural anesthesia. So you don't need to subject them to general anesthesia. Selected cases. So my anesthetist gives only epidural, and we have done both VATs. We have done even couple of open decortications under only thoracic epidural. So and they do well. Most of them do well. You can't do if you compare the same procedure done under general anesthesia, if I can do 100% under GA, I can at least do almost an 80% under pure thoracic epidural without a one lung ventilation. But still, you can at least get away with the focus of infection, and these patients still do better.
I think you
if
have
I
a
have,
point.
yeah, continue.
It's an excellent point, actually. The comorbidities are going to be same for pulmonologist or a surgeon. Only the anesthesia is going to different. And a surgeon can do a better job than a pulmonologist, actually. So I think even in a complicated case with comorbidities, I think with lesser amount of anesthesia like thoracic epidural, I think surgeon should be doing the job so that the results are better.
So if I have to summarize what we have spoken up till now in the cases of empyema, like if it is grade 1, early grade 2, we intervene, grade 2 and grade 3, the surgeons intervene. And if the patient is maybe a borderline case, we need to discuss with the family and keep the ICU team and the anesthesia team on the same page, and maybe modify our anesthesia, and maybe we can do almost a complete job. 80% is still a good job for a patient who is probably not going to have anything, a good quality of life if not operated. So that was good to know. Now coming to Dr. Jayaraman, now next question to you. Most common scenario I'm giving you. It is a case of pulmonary tuberculosis with a cavity and a hydropneumothorax. It's very common in Rajasthan. We used to see this a lot. Now, when would you like your surgeon to help you in such a case? A patient has come to you, pulmonary tuberculosis, cavity, and a hydropneumothorax.
Okay, thank you, Makhil, for this nice question. The patient is on pulmonary tuberculosis with cavity lesions with hydropneumothorax. So clinical radiologically, my suspicion is patient is having this BPF, bronchopleural fistula, one of the cavity, leaky cavity or ruptured cavity in the pleural cavity, which causes the air fluid level, which causes the fibro, that is air fluid level. This is the one, hydropneumothorax. So, which eventually needs a drainage by putting a tube thoracostomy. So, first thing, I'll put the tube thoracostomy and see the drainage and all. Once the drainage is completed, I'll see any air leak is there or not. So, any air leak, if it is a mild air leak, so I'll wait for 3 to 5 days time, maximum 3 to 5 days time. So, if it is a persistent air leak, if it is a persistent prolonged air leak in the air bubbling, so while inspiration or coughing or expiration, so maximum patient is on ATT with supportive care, nutrition support, everything. Maximum we can wait for the 2 weeks time. So 5 days minimum, maximum 2 weeks time we have to wait. So maximum 14 days time, the air bubbling slowly settles. By the time we give you all the ATT, all the medications. So maximum after 14 days, still persistent air leak, PAL, persistent air leak. Then we have to think in terms of the surgeon involvement in the form of how to tackle this BPF, bronchopleural fistula. So now in this juncture, I call upon the thoracic surgeons to intervene, whether to close the BPF, what methodology we have to close. We have had some interdisciplinary meeting with thoracic surgeon and myself and the radiologist about the thing, whether to proceed with the bronchoscopic interventions, close the BPF in a case of mild to moderate, or if it is a massive one. So needs a thoracic surgeon to do the VATS and close the BPF closure and all. So this time I will call the thoracic surgeon for this kind of a persistent air leak more than maximum 14 days later. Yes.
Yeah. So if the surgeons have any view on this, otherwise I think I agree with you. It after 2 weeks of AKT is when, if you see the ICD is not helping the patient completely, you might want the surgeon to step in. Do the surgeons agree on this?
If I can come in, Mehul, I think I would love to have Dr. Jayaraman working with us, that he refers the patient so early. See, a counter question what surgeons say, which is, I think with time it has changed, that they say the classical teaching is give ATD for 3 months and then only touch it. Because the chances of BPF are high, your stump might break down. But over a period of time and having dealt with cases like Dr. Jayaraman said, is that, at times we go in, we do not know whether the patient has tuberculosis. It's only after the surgery we come to know the patient had tuberculosis. And we have not waited 2 months. In fact, we're not even given ATT. So the argument saying that, you'd wait 3 months, I'm not very convinced by it. Depending on the condition of the patient, we need to go in, as he said, 2 weeks max, or even 3 weeks. So it is not essential that you need to give. If a patient can have, in a case approved tuberculosis, if he can have for 3 months, then great. But sometimes the condition could be rapidly deteriorating. There could be massive air leak. then putting on a ventilator is going to be counterproductive. So in those cases, I wouldn't wait. I hope I've not confused all of you, but depending on the patient's condition, ideally, yes, if the patient is stable, 3 months. Otherwise, go in, no matter
So,
what.
so if I would put it in a different perspective, when we get, I'm digressing a bit, but if you have a patient of active tuberculosis and you have to give fitness for any other surgery, like say a CABG or something, we usually wait for 2 months. We give 8 weeks of AKT, make the patient sputum negative to so as to say, and then refer the patient for any cardiac intervention. Here, the problem is if I don't intervene, my healing won't happen along with the AKT. So here the surgeon has to step in. So sometimes we don't wait for 8 weeks, as you said, sir, but 2 weeks is minimum. We try, at least I try to wait for 2 weeks, because at least some amount of AKT has to go, some healing process has to start. Then and obviously, as Dr. Jaraman said, nutrition has to be built up. And in such a case of empyema, a tuberculous empyema, a surgeon can step in at this point, where the decortication and closure of the BPF can work. Yes, some maverick physicians would try to do it bronchoscopically, but probably sometimes these leaks are bigger and may not respond to a bronchoscopic intervention. So I think we've answered all the questions on empyema. There was one question from the audience. I'll go back. Dr. Sankit Gadam wanted to ask when to consult a surgeon in case of empyema. I think we've answered that. So let's move on to the next intervention that we have is a case of pneumothorax. Dr. Jyoti, I will come to you. We have a case of a spontaneous pneumothorax, and you have taken the patient up for a thoracoscopic pleurodesis, but you find a lot of air leak is there and blebs are there. How will you handle this?
Thank you, Mehul, for asking this question to me. So as we know that spontaneous pneumothorax can be divided into two parts: primary spontaneous pneumothorax and secondary spontaneous pneumothorax. Secondary spontaneous pneumothorax is due to some underlying lung diseases, like most commonly COPD, tuberculosis, cystic fibrosis, bronchiectasis, etc. And primary pneumothorax, the most common etiology is presence of bleb or bulla. This is the most common etiology for causing primary pneumothorax, spontaneous pneumothorax. So management for primary spontaneous pneumothorax as per the BTS guideline and ACCP guideline, little bit different. But in one point, the both guidelines say the same thing. If presence of bulla or bleb, we have to take opinion from the surgeons, and these cases should be referred to surgeon. So surgery is the best practical approach for managing these primary spontaneous pneumothorax.
Yeah, so if you do detect the blebs or maybe the bulla or on the CT scan before you plan your intervention, then straight away refer to a surgeon. If you have put an ICD and then you are going for a thoracoscopic for a pleurodesis and you find blebs which are small enough, they might just close if you spray the talc properly. But if they are bigger ones, then probably your intervention is not going to work. And there is where you should know your limits and hand it over to your surgeon colleagues. So small blebs, maybe it might work, but if you have bigger ones, if you have a recurrent pneumothorax, in such a case, also the surgeon takes it over. Nasir sir has shown very beautifully how he's removed blebs with the help of, and bullas with the help of staplers and cautery, and all those things can help. So I guess such cases, recurrent pneumothorax, bigger blebs, bigger bullas, or if it's a secondary spontaneous, sometimes you might want a surgeon to step in.
Can I add a point?
Yeah.
So regarding the role of medical thoracoscopist actually in pleurodesis of pneumothorax, spontaneous or primary spontaneous or secondary spontaneous. Generally, what we do is we wait for the air leak to settle down, then we do pleurodesis. So a tube thoracostomy related pleurodesis, that is pleurodesis done by talc or betadine through the chest tube. Is it non-inferior? Because it's almost, I think a lot of studies have shown that the efficacy when the pleurodesis is done through the chest tube versus the efficacy when it's done to the medical, like VATS or medical thoracoscopy, is almost same. So in my practice, what I generally do is wait for the air leak to settle down, then do an pleurodesis through the tube itself. I would not actually venture to do an medical thoracoscopy. If the air leak is not subsiding, then there is always a role of surgeon. He needs to tackle the staple, the bulla. Actually, that is where actually probably the surgeon's role is needed. I would never venture to do a medical thoracoscopy in these cases. Actually,
Okay.
I want to know whether there is an evidence which shows that a thoracoscopic fluorodesis is better than a tube thoracostomy fluorodesis in these patients?
No, current evidence has come up. You are right. Current evidence has shown that if you have a talc slurry in such patients, it will probably be non-inferior. But since it's the age-old teaching, and we have been practicing now since years,
True.
that if you spray talc, if you do a poudrage, probably it might have a better outcome. And that thing takes time to come out of it. But if you are doing a thoracoscopy, my question was that if you're doing a thoracoscopy and if you find blebs, then probably you are right. That is where you don't want to venture out. But air leak, if it is persistent in a case of pneumothorax, then the surgeon has to take the case. It is not your case, and you're obviously not going to do any intervention of putting a slurry or doing a medical thoracoscopy in such a patient where the air leak is persistent. And we've had a couple
Can
of
I come
questions
in for a moment? Mehul?
Yes, sir. Before you
Can I
intervene,
just
sir, I would
maybe-
add one or yes, sir. Yes, sir. Go on.
Sorry, Mehul. See, there's one
Yeah.
concept which is there among pulmonologists. We as surgeons, suppose you do pleurodesis, a young man, right? So they do pleurodesis, it may work. It doesn't work, then what happens? It's sent to the surgeon. And once pleurodesis is done, it is like trying to free the lung, removing the wallpaper from the wall. You know what happens when you're taking the wallpaper off? It comes in bits. So what happens when a failed pleurodesis occurs and then sent to a surgeon? It is hell because they bleed profusely and there's tremendous air leak. Now I am aware, but sometimes when it happens and your dear friend does it, we go in and it's hell. It's terrible morbidity for the patient. Now the counter argument given is initially for lung transplant, they used to say pleurosis done means you cannot do a lung transplant. But that didn't make sense to me even then. Because in a lung transplant, what you're doing is you're not preserving the native lung. You're just throwing that away. So there's no question of an air leak coming up. And it took so long for my dear transplant surgeons to understand that. Now they say, okay, pleurodesis, hum log karenge. I mean, post pleurodesis we'll do. But these are for patients who have a lung which is functional, which has become, it's horrendous. After a failed pleurodesis, it's terrible. That, lung bleeds, the air leak is tremendous. I wouldn't like to be in that situation. I normally would say no, but when good friends, somebody does it, we have to oblige them.
So, but if
So
you have
unless
The thing is that there is a chances of recurrence is also there for TAP pleurodesis if we do in these cases like where the bulla and bleb is present and there is a persistent air leak. Might be it is mild, but when we do a pleurodesis, so there are still a chances for recurrence in these cases are higher. So better to send these patients to the surgeon is I think the best option.
Yeah, but if you have done I would say a talc slurry, like Dr. Vishwanath was saying, just put in a talc slurry and then it fails, it's not uncommon that it fails, it can fail. And then where the surgeon steps in, then probably, as he's saying, it is going to be hell for him. But that is what, sir, we tried. And since we were not able to, that's why we hand over the case to the surgical colleagues in such a case. I'll just take one question from Dr. Sapan Kumar, role of blood patch in pneumothorax. Anybody wants to take role of blood patch in pneumothorax?
So not in a case of primary spontaneous pneumothorax, but pneumothorax due to other causes like post-operative complications and pneumothorax due to some other traumatic causes, then other causes, not the primary spontaneous. Then there is a role of some studies related to 50 mg blood patches given for the healing of this persistent air leak. But there is no robust data. There is no randomized controlled trial. So everybody is doing their own convenience and as per their expertise in this. So as per the availability of, so we are not doing this autologous blood patches, but it is given in literature and some of them are doing it and not in a primary spontaneous pneumothorax cases.
So I can add
So-
one of my experience. We have tried during our PG. It did work in a few cases, but now you have povidone iodine, good data with povidone iodine, which is freely available and easily doable. So I think the role of blood patch should go down. Yeah, Dr. Amol, you wanted to add something?
Yeah, so as Dr. Jyoti rightly said, we use blood patches for sometimes when you have a post lobectomy or a post decortication residual space with a minimal air leak. That is where we still sometimes use an autologous blood patch, but otherwise except for this, there's no other indication, I think.
Okay, good, good to know. And Dr. Amol, now I need to come to you only. What are the interventions the surgeon can offer in a case of a spontaneous or a case of a pneumothorax, for that matter?
So the first thing is when in primary spontaneous pneumothorax, when you have blebs or especially bulle, so bullectomy with stapler, similar to the video what Dr. Nasser showed. We do a bullectomy. We now do most bullectomies by uniportal VATS. So we can do a VATS bullectomy. Along with a bullectomy, you also always have to combine it with either a pleurectomy or an abrasion pleurodesis. I would use talc pleurodesis only in patients whom the underlying lung, otherwise the lung is unhealthy. So that is not primary spontaneous. I would say that is secondary spontaneous pneumothorax. In those patients, I might use talc, but as far as possible, in most of my cases, I do an abrasion pleurodesis and pleurectomy in some selected cases. So that is number one.
Okay.
Number two
Mm.
is in cases of secondary spontaneous pneumothorax with an air leak, you have to at times go in and see what is the cause of that air leak. Sometimes there could be a segment or a lobe which is destroyed, there might be a cavity which is opened up. In such cases, they do require a more extensive resection, maybe a segmentectomy, a wedge, or sometimes even a lobe. So there have been some cases, even Dr. Nasir has a good series of patients in post-COVID air leaks, where sometimes we did 16 of them during the post-COVID phase, where some of them did require a wedge resection to stop that air leak. So that is the second intervention that we need to do in pneumothorax. So these are the two most common things for pneumothorax that we do. One is bullectomy, and second thing is sometimes resections to close the BPFs. And not always resections. Sometimes when the underlying lung is too unhealthy for resection and the air leak is small, you can even do only stapling or suturing, pledgeted sutures with an intercostal muscle flap or something to close the air leak. These are the different interventions.
I hope that answers the questions from Dr. Shriyami Saha and Dr. Vishal Singh Chauhan, because they've asked similar questions in such cases. So good. Coming to, apart from pneumothorax, Dr. Jayaraman, is there any role of a surgical consult in the management of a malignant pleural effusion? If you have a case of malignant pleural effusion, would you require a surgeon's help somewhere?
Yes, Magul, this is a wonderful question. So, role of surgeon in a malignant pleural effusion. Once we confirm the diagnosis of malignancy in the pleural cavity, so we form we usually present in a case to our tumor board meeting, which consists of the thoracic surgeon, oncologist, and the pulmonologist, discuss the case, what are the treatment options available in this case. Mostly in a case of malignant pleural effusion, the usual problem is the shortness of breath recurrently because of the recurrent pleural effusions. So in that case, we do the intercostal drainage. There is a tube thoracostomy and the pleural disease using the chemicals like talc and bleomycin, all the codeine iodine. So if it is any failed pleural disease, again patient is collecting the fluid and all, and any trap lung or failed pleural disease, we are thinking in terms of IPC, indwelling pleural catheter. So, and also in a case of mesothelioma, this is one of the notorious primary malignancy of the pleura we come across. So, in that cases, definitely the surgeon role in a case of stage 1 or stage 2, the pleurectomy or a pleurodemonectomy, the role is very important. The radical surgery is one of the treatment options for the stage 1 and stage 2 of the malignant mesothelioma. So, in that turn, definitely we know the surgeon from day 1 itself. So this is my take on this malignant pleural effusions. We try to do the pleural disease. If it is a fail, we plan to do the IPC. That also fail means definitely for the pleurectomy purposes, the patient is stable, definitely we involve the thoracic surgeon to do the pleurectomy and other procedures. So this is what we go ahead. Yeah.
Yeah, so that's perfectly making sense that you first try malignant pleural effusion by giving the basic chemotherapy, and along with that putting an ICD or an IPC and trying to achieve pleurodesis by either of the two. And if it fails, we refer the patient to Dr. Nasir, which he'll not be happy to get because we have tried pleurodesis and we have failed. But that is when the surgeon's help comes in because the patient is breathless. We have to try everything in our hand to make the patient better. So coming to Dr. Amol, Dr. Nasir showed a case of a chylothorax. So what is the ideal time for a surgical intervention? Most of the patients come to us as physicians. We tap it, we find it is chylous fluid, we send it for examination. We might put in a chest drain, but then we have to refer to a surgeon. So ideally, when would you want the patient to come to you?
So, as per guidelines, they say that if the drainage is more than 1 liter per day for more than 5 days, or if the chylothorax is persistent for more than 2 weeks, irrespective of the quantity of drainage, these are the patients who are indicated for surgical intervention.
Okay. So maybe first 5 days we manage medically, and if the drain is continuous, maybe the diet management is not working, and then you might want to intervene. I've got one question from the audience. I think it is directed to the surgeons. What are the treatment considerations in a trapped lung? So, Dr. Amol, Dr. Nasir, both of you can take it up.
So trapped lung is usually because of the visceral pleural thickening, and it requires a decortication. The entire visceral pleural peel has to be completely removed off the lung surface. Complete 360-degree, the entire lung has to be completely free. In certain cases, wherever possible, we even try and open up the fissures to help better lung expansion. And the lung has to be completely mobilized up to the hilum from all aspects. So that is, then the lung would completely re-expand. So basically, it requires a thorough decortication.
Okay. Okay, so I hope that answers your question, Dr. Bhavraja NP. And coming to Nasir sir, sir, you saw, and actually the last webinar was on the such maverick pulmonologist who enter the gray zone and want to break the glass ceiling of what they can achieve. So what are your thoughts on pulmonologists getting more bolder with their rigid thoracoscopes, and what are the pitfalls or places where we need to be wary of, or we should be aware of where we are going?
Really, no comment on that. So I will leave it to the audience to judge for themselves and take a decision as to what they will do for that patient. Absolutely, I would like to refrain from a controversy with my friends.
Yeah, surgeons would want that. I mean, see, all of us wants what's best for our patients. Nobody wants that they should, as you said, nobody wants to be a guinea pig, not even put ourselves in the patient's shoes. So if you are confident of doing it and if you have done enough cases, ideally, I would want to start off such cases with the help of a thoracic surgeon, like say Amol is there with me and I'm operating. And then as I get bolder, maybe take a couple of extra steps without him being present. But initially, yes, as you're starting off, these cases, gray areas should be handed over to the surgeons and should not be ventured into. Now, let's move on to the next part of our discussion. And I'd like to get Dr. Jyoti into the discussion. Dr. Jyoti, you have been using cryobiopsy for pleura. So first of all, tell me what has been your experience for using cryobiopsy?
So, as we know that there are a lot of methods of biopsies like rigid forceps biopsies and flexi forceps biopsies. So, still undiagnosed pleural effusion diagnosis made by medical thoracoscopy, but still 20% cases are undiagnosed. So, we are chasing towards these 10 to 20% cases. How to enhance our yield in diagnosing these undiagnosed pleural effusion. So for last 3 years, I am using cryobiopsy in our department, and our experience is good. But not all the cases I go for cryobiopsy. So those are the cases which have high thickened pleura, and where is a difficulty in taking biopsy from the same flexi forceps biopsies. So in these cases, we are doing it, and we are getting a good results. We are getting a good yield as per the lecture taken by the Dr. Vishwanathan. Very much appreciated. The lecture was touched all the of cryobiopsies, how to take it, and what is the diameter of this cryoprobe. So same in our department also, 1.7 millimeter of cryoprobe with the semi-rigid thoracoscope of LT of 170. We are using it for diagnosing undiagnosed pleural effusion. And where the thickened pleura, where the difficulty is in taking biopsies from the flexi forceps. So that in that cases we are doing cryobiopsies, and we are getting a good results, and we are getting a but there is a one challenge I would like to tell you here, that because we are dealing with the tuberculous pleural effusion very high, so in that cases we are getting a lesser result in cryobiopsies. The yield in malignant effusions and malignant diagnosis yield is about 70%, but in the pleural tuberculosis cases, yield is about 22% because of the freezing effect of this cryoprobe. So that is the domain where we have to work, and we have to do more of the research in this area. So it's still we are struggling to diagnose tubercular pleural effusion. So this is my expertise, and this is my experience in cryobiopsies from our department.
If I have to add to that, you said you're getting less positives in pleural tuberculosis. So
Yeah.
you're getting less positives on the histopath or less positives in the cultures?
Culture. So
In the
we are
cultures.
getting in culture histopathology, we get the granulomas and all, but finding in culture is yeah. So well taken. Your point is well taken. In culture, we are getting difficulty to diagnose this tubercular pleural effusion.
Okay, so coming to you, Dr. Jayaraman, I mean, she has already described some of the indications. Is there any other indication where a cryobiopsy would be used, or any contraindications where you would not want to use a cryobiopsy? Sir, you're on mute. Sir, are you on mute? Yeah.
Oh, sorry. See, already Jyoti ma'am mentioned clearly about that indications of cryopleural biopsy is the exudative undiagnosed pleural effusion, the high suspicious of malignant pleural effusions. So the cryopleural biopsy, in the case of malignant pleural effusion, so we have to take a large chunk of tissue. Already Vishwanathan clearly told about this his presentation. Need more tissue. So greater tissue needs for the further molecular testing and genome sequencing and all. We need a more tissue. Just a simple forceps biopsy, the testing facility. Again, pathologists will ask inadequate tissue. We need a more tissue and all. So role of cryobiopsy is clear indication. If you think in terms of malignancy, better you have every gadget you have. Better go for the cryobiopsy. Take the large chunk of tissue. It has less stress artifact, and you can maintain the cellular architecture. So we won't lose any diagnostic dilemma and all. So we can accurately diagnose, and the subtype for the targeted immunotherapy, for the immunogene sequencing. From the gene sequencing, we can detect all the receptor mutation study, everything. For that, in the malignant pleural effusion, cryobiopsy will help in diagnosing and delineating. In-depth tissue also we can take easily without any cross artifact. This is another indication. Contraindication of cryobiopsy, this is one kind of procedures in the pleura. So any other procedures contraindication. So obviously any uncorrected coagulopathy, bleeding diathesis, any severe respiratory, cardiorespiratory failure, or renal failure, liver failure, or any severe patient is on ventilator, not able to perform things. This is all general contraindication for the any procedure, including the cryobiopsy also. I don't think any specific contraindication. Jyoti ma'am, you can update any specific contraindication for cryobiopsy.
So no, sir, not very specific. All the contraindication are similar to just like a medical thoracoscopy contraindication, like absolute contraindication and relative contraindication. Most common if bleeding diathesis is present and platelet count is less than 60,000 and INR is more than 1.5, we could not go for cryobiopsy in these patients.
Correct. Yes. Thank you.
Yeah, so I think one more indication we can add, if your wife is a pathologist and you need a cryobiopsy, you need to give her the more tissue so that you don't get shouted at. Okay. Dr. Vishwanath, I need to ask you this question. Like, we use cryo equipment in our thoracoscopy suites. We use it in a bronchoscopy suites. This is just a question I just popped in my mind. Is it worth the investment for a pulmonologist? I mean, and if you have to invest in a cryo equipment, what kind of probes should we invest in?
So I think I would say that it's a very, very useful tool in the armamentarium of pulmonologist. both in the critical care as well as in the pulmonologist here. Because in the critical care, you have a lot of patients who come with lung collapse, mucus plugging, and bleeding actually, especially patients on ECMO. These are the patients earlier who used to take out the mucus plugs or the blood clots with the forceps. It would take us 45 minutes, 50 minutes or something hours together sometimes to take up the clot when there's a whole lung collapse. With the cryo, it has become very, very easy to clear the lung collapse and the bronchial blockage actually. So in the ICU, it's going to be very, very useful. And we are going to have all these kinds of patients in our ICU when you are managing ARDS patients and everything. And coming to the regular pulmonary practice, I would say that now the indications are expanding. Earlier it started with an cryo lung biopsy. Now we have started doing lung nodule biopsy with 1.1 mm cryo probe. And again, now we are doing a cryo EBUS TBNA with the same 1.1 mm probe to get a larger tissue. And we need more evidence for that, obviously. But so I think it's coming into many, many fields actually. And the cryospray therapy is going to come, but that is still investigation. At least I can say with confidence that cryo lung biopsies, lung nodule biopsies, and then the cryo EBUS and the pleural biopsy, again, as I said, the role is not clearly defined, but if you require more tissue, especially in malignancies, you need to take it actually. And in tuberculosis, it can be counterproductive. One point, a very nice point raised by Dr. Jyoti, actually, even in the chest meta-analysis in 2020, there they have shown that when cryo was used, the culture positivity rate and the gene expert positivity rate was lesser compared to the forceps group. That's because your cryo is killing the tubercle bacilli. It's going to be a valuable tool in the suspected pleural malignancies. So, and if you're investing in the probes, actually now I think there are only two probes which you are going to invest in. That is the 1.7 cryo probe and other is the 1.1. 1.7 will be helpful for most pulmonologists, especially when they're doing the ICU work or when they're doing lung biopsies. 1.1 will be useful only if they have a radial EBUS and if they plan to do lung nodule biopsy actually, or a cryo EBUS.
Okay.
It's
Okay.
a perfect tool to have actually.
Yeah, so the more you get experience with such tools, maybe you can keep on expanding its role and maybe in trying out new things. We have one question from the audience. Dr. Shehbaz wants to know, is cryobiopsy better than a rigid biopsy? I think it has well been taken, but Dr. Jyoti, you can always add to that because you've been using it. Like
Yeah.
with semi-rigid or with rigid, and is
So,
it better than rigid?
yeah, so I would like to tell you here, there is a one study which compare the rigid forceps biopsies and the forceps biopsy as well as cryobiopsy. So in this study, they have shown that the rigid biopsy has a superior or some edge over the cryobiopsy. So if you have a rigid biopsy and rigid thoracoscope in your OT or in your setup, so I don't think there is a need of cryobiopsy. But if you have a semi-rigid thoracoscope for medical thoracoscopy and you have this cryoprobe, I think this is a wonderful tool, and there is a little more data is required because all the studies are observational studies. Some meta-analysis is also there. They have compared very beautifully with the flexi forceps biopsy as well as cryobiopsy. So they found that there is no difference in the yield, but the tissue was very high. There is a less crush effect, and they have deeper penetration, and we have beautiful and easily diagnosed mesothelioma in that cases. So if you have a rigid, so answer is if you have a rigid, so there is a comparison, but rigid is superior to cryo as per the one study, which was the 84 patient study. It was a bigger study, but data is still less. So further more data is required. So as of now, answer is no, but future will come.
Dr. Jeremy, do you have any other data, like what is the current data on cryo? Because that is the most common question asked in the chat box.
Yeah. See, the role of cryobiopsy, if you deal with a malignant pleural effusion, there is a malignancy, needs a more tissue, obviously. In the case of malignant pleural effusion or primary malignancy, mesothelioma, or the secondary metastatic from the lung or the breast or nearby organ, the larger chunk of tissue will help in the molecular diagnosis and other immunogenetic diagnosis, very, very useful for the targeted therapy for the oncologist. This is the one entity, is a very, very important thing for the cryopleural biopsy. Otherwise, if you practice the rigid thoracoscope and rigid forceps biopsy, already Madam mentioned, this is superior. Overall, if you have the armamentarium of every gadgets you have, in a majority of the malignant pleural effusion, you deal with the cryobiopsy is yield rate and other chances of getting a diagnosis maximum in the case of cryopleural tissue biopsy. Yes.
Yeah, and I'd like to ask this question to Dr. Jyoti. I mean, since you're doing, what is the rate of bleeding that you have noticed in a cryobiopsy patient, and how do you handle it?
So as of now, we have not seen very moderate to severe cases of bleeding during cryoprobe biopsy through medical thoracoscopy via semi-rigid thoracoscope, and chances of bleeding is very less, and they are mild, just like a forceps biopsy, and it can be managed conservatively. There is nothing to worry during cryobiopsy. I have not seen any case of major bleeding, and all the studies and all the meta-analysis also reported only the 1 or 2 to 4% chances of mild bleeding is there, not moderate to severe in any of the study. So as of now, there is no severe bleeding can occur, but it can happen when the intercostal artery or internal mammary artery can be damaged. Then it can be happen. So you need surgeon at that time for management of these severe cases, or maybe you have a APC or electrocautery in your armamentarium to manage these complication of bleeding, as you managed in the cases of medical thoracoscopy as in your operating theater.
Yeah, so I mean, there is one question like how to deal with a massive bleeding. So maybe Dr. Amol, if you're there, I mean, how would you deal with a massive bleeding in the pleura? I mean,
So, if it is coming from the pleura, if it is massive, it is most likely from one of the intercostal vessels. So, you can initially try. So, the way we do it is try controlling it with a bipolar cautery. And if it doesn't stop with that as well, then sometimes you have to actually take a suture there to stop the bleeding at that site. So, because mostly it is from one of the intercostal vessels.
yeah. Thank you.
What is the role of suction cautery, sir? Suction cautery, both the same? Is it the same or different, sir? Suction cautery.
No, so you suck it, and with one suction instrument, when VATS we have two, it is two separate instruments. So we have a VAT suction to suck the bleeding, see the spot, and then second, a long laparoscopic bipolar instrument to cauterize.
Fine.
Okay, so up till now, I think we've had a lot of good questions which were clear cut, and now we have one question which is going to divide the house, and I would like to ask the surgeons and the physicians for this. This question is from Dr. Jinesh Doshi. That suppose if it's a stage 1 empyema, and patient is to decide on a surgeon and a pulmonologist for his treatment, whom should he prefer? Who is statistically more likely to give a better result? So first let the physician speak, then I want the surgeon's answer on this. Anybody, any physician who wants to step into the ring with the surgeon?
Yeah. Stage
Yes.
1 empyema, there is the exudative phase. Patient usually presents with a generalized mild to moderate collection of fluid in the pleural cavity. So, pulmonologist perspective, under the image guidance, real-time ultrasound guidance, we take the pleural after imaging, ultrasound guided pleural tapping. If it is a frank pus in the case of moderate biothorax, directly we put the tube thoracostomy and drain and start the antibiotic, common antibiotic, broad spectrum, both aerobic, anaerobic, and all we start. Once the report comes, we de-escalate. In the case of generalized stage 1 exudative uncomplicated pleural effusions, is going for pus, there is a biothorax. So we, as a pulmonologist, as interventional pulmonologist, we can go ahead, tube thoracostomy and all. Or if you want to take a biopsy, also do the thoracoscopy. Do the thoracoscopy and take the biopsy from the parietal pleura. So our area is mainly to parietal pleura. As interventional pulmonologist, our area is only working areas of parietal pleura, not the visceral or diaphragmatic or apical pleura. Only diaphragmatic. That too, the posterior parietal pleura. Take the over 5-6 pieces of biopsy and come out, put the ICD and come out. So this is the way we proceed in the stage 1 exudative empyema. So others comment, please.
Now let the surgeon answer to this.
I have a comment actually. So sometimes it's difficult to differentiate whether it is stage 1 versus stage 2, and whether it could be difficult and whether you'll be able to do it yourself completely. In that kind of scenarios, either you refer to surgeon if you're not able to clearly define whether it's a stage 1 or not, or you do start with the help of a thoracic surgeon.
No, stage 2 easily we can identify by ultrasound and CT scan multiloculations. That's it. Thickened pleura, thickened visceral pleura, multiloculations. Multiloculations means always the surgeon's mind, they will do decortication. This is very easy. What, Bahul?
Let the surgeon answer.
Yeah.
No, I quite agree with Dr. Jayaraman's view, and ultimately the decision is by the patient, like what he wants to do. But there are, an interventional pulmonologist, a good thoracoscopist, can deal with stage 1. Coming to that nice question which Dr. Jayaraman raised about suction cautery, that's quite effective. It's a single instrument which will suck at the same time it cauterizes. Now, problem when there's a bleed, it is pooled, blood is pooled there, so the cautery does not work. So you need a dry field, and dry field means you need to suck it out and then cauterize it. But this instrument, what he said, is quite effective, suction cautery. I have to support that statement of his. And in fact, I showed it in my video.
Yes, sir.
Yes, I
You
use
showed
the
it.
suction
Suction
cautery.
cautery. Thank you.
So maybe what my view on this is stage 1 is always going to be physicians to have been going for a VAT surgery or a major surgery for a stage 1 empyema seems to be an overkill. Just because you have a surgeon, maybe the surgeon can do a complete job, but in stage 1, you can avoid surgery. And all our medical efforts are towards avoiding any surgery in any form of disease, not just empyema. So whatever minimally invasive we can do is beneficial for the patient. And if the patient still wants a surgery in stage 1, then we need to refer to a surgeon. And I agree with one of the comments by Dr. Sarvinder saying that how many surgeons would want to intervene in grade 1, but sometimes patients do chase. Some well-educated, Google-trained patients would want the surgeon to intervene. So there, I think the surgeons will also say no, but I agree with the theoretical question here. And the next point by Dr. Sarvinder is whether the cryoprobes he was aware was 1.1 and 1.9 mm. But I think there were many sizes available. Now 1.1 and 1.7 is the most common cryoprobe available, if I'm not wrong. And one comment by Dr. Sunita Narayan, theoretically, cryosampling shouldn't affect the nucleic acid amplification method, unlike in cultures with respect to tuberculosis. I'm guessing maybe it's the fast, rapid freezing and rapid thawing which is leading to the negative test. Does anybody have any other idea why that nucleic acid amplification tests are negative?
Yeah, mainly the freezing effect, which causes the false negative report in the case of tuberculous pleuritis. That's why I'm telling from the beginning, cryobiopsy more in favor of more for the malignancy diagnosis. For the brain diagnosis, simple forceps biopsy and culture, the yield rate is very high. Already Jyoti ma'am clearly mentioned about her presentation.
So if I have to summarize this, maybe if you have a rigid thoracoscope, then probably you don't have to worry about getting a cryobiopsy or anything. But if you have a semi-rigid thoracoscope and maybe your pathologist has not been happy with the last results that you have given and your suspicion of malignancy is high, maybe then you might want to use the cryoprobe. On table, you might want to decide, okay, this looks more malignant. I thought it was tuberculous, but it looks more malignant. I need to use a cryoprobe. So if you have the machinery with you, then you can choose. I would suggest don't go with the prefix mind that I'm going to do a cryobiopsy in this patient. Maybe take it on table, the decision on table. So I think we have covered a lot of questions. I'm just going through the questions put in the chat box, and I think we have covered almost everything in some form or the other. Any contraindications? Now we have taken those. Okay, one question by Dr. Vishal Singh Chauhan: when to avoid surgery in a trapped lung? I think trapped lung deserves a surgery unless patient is not fit. If there's any other view.
Yeah, it's a very good question. Can I take that question?
Yes, definitely.
Yes. So the problem is, the lung is fibrosed. Your decortication is not going to work. I'm seeing from experience that we have no way of saying preoperatively that your decortication is going to succeed. So basically, I would say a patient who's had a long-standing chronic disease, a trapped lung, the chance of expanding is not very high. So I would say the chronicity is one factor, and the other due to fibrosis. So unless a lung expands, it does not happen. So early stage, early intervention, yes. But say, how do we see these cases? Say, for example, a large tumor, like you have a solitary fibrous tumor sitting on a lung, and then it gets, patient has pneumonia because the lung is collapsed, and then it develops empyema. That lung is not going to expand. We have done it. We have taken out the tumor, but then we have found it hard after decortication, the lung still remains collapsed. And at times, after 3 months, we had to go in and resect that area out. So chronicity is a factor which will determine whether the lung will expand or not. And the underlying pathology, say tuberculosis or very bad infective pathology, will not allow it to expand. And further, I've seen, as you've had a very difficult situation is malignant pleural effusion. Again, long-standing, they put multiple aspirations, they put a chest tube, and then they send it to the surgeon. I personally have had very unhappy experiences. We've tried decortication in those patients. It doesn't work. We've had various discussions. So I would probably keep away from those patients. Maybe put a pleuro, and a peritoneal shunt, even IPC gets blocked. But again, they're not expected to live more than 6 months to 9 months. So a decortication of a trapped lung in malignancy is a huge challenge. Amol, probably you can add to it.
Completely agree, sir. In malignant pleural effusions, in spite of decortication, firstly, decortication itself is difficult. And even if you try to do it, the lungs don't expand. They don't do well. And it's stuck in a very different way. The lung even doesn't get mobilized the way it gets in a non-malignant case. So their decortications don't help.
Now, so if your
Also,
post-surgical morbidity is not going to improve theoretically, then probably that case should not be intervened either by the surgeon or the physician. And as far as trap lungs, sir, you made a very good point of chronicity. I mean, I don't know, there is no definition to that, but many times patient comes to us with an ICD for 3 months, 4 months, 5 months, and it's a tubercular case. ICD, lung is not expanding. We do refer to a surgeon, but then we also sometimes fear whether the lung will expand. It's a trapped lung. It has been there for 4 months. Tube is there, or maybe sometimes tube is removed. It is just removed and the trapped lung is there seen on the CT. Those patients may not respond. But so there is evidence that we would want to make the patient better. So we refer the patients to you guys. Maybe you can do something there. So
I
there are
quite agree
gray
with
areas.
you. Yeah, I quite agree with you, Miles, because there's no cutoff line,
Cutoff line.
like 3 months, 6 months. But generally, say I'm talking about a year or more, but not
Yes, sir.
6 months. 6 months,
Yeah.
they should be given a chance.
Yes, sir.
They should be given a chance. But I'm saying we should be cautious, we should be aware
Yeah.
and counsel the patient. It may not fail, but they should be given a chance. You're quite right.
So I think we have had, yeah.
Mehul, can I make a point here?
Yeah, sure.
So such patients, Mehul, where the ICD is in for months together and the lung parenchyma itself is unhealthy. So this is where, in spite of decortication, it's never going to help. And
Exactly.
and it's a young patient. It's not too many months of AKT. That is the catch-22 situation. So these patients, if there is an empyema, if the tube is still draining purulent fluid and the patient is kind of septic, these patients, I think, would benefit by an open window thoracostomy. So that helps them to get rid of the tube. And initially, they do require very frequent dressings. It's a little messy, but as the chest starts drying up, the frequency of dressings goes down. The patient can easily manage those dressings at home, and they do well. They come out of sepsis very quickly, and it's a better quality of life after few days. Initial few days, yes, it is morbid, but later on, their quality of life does improve a bit.
Yeah.
Dr. Nasser, what are your thoughts on this?
Absolutely right, Amol. It will, kind of open window thoracostomy. There are two types, but I won't get into the two. One is a permanent window, the other is a temporary window. This is for a space, as he said, which is infected. So, and does not address the underlying lung, though. It is just to make that place, that space sterile and get rid of the tube. It is a very effective thing. and very less morbid and not so difficult. And as he said, after a while, the patient gets used to it. He might have to just keep a pad there, but the quality of life, we have patients, I'm not trying to trumpet my patients who have seen their children get married and so on and so forth. It's a very useful procedure in a patient where the lung doesn't expand and you're in infected space. And that is a very good point you made, Amol.
And in some of these patients, sir, we've even seen that as they heal with the anti-tuberculous drugs and all, at times even with an open window thoracostomy, we've seen the lungs expanding better, and then subsequently either the lung completely expands and you just have to close the window, or it will close by itself, or after a few months you can do an open decortication or something and still end up saving the lung. Which if you had tried an intervention right in the beginning, you might have, the patient might have landed up into a lung resection.
Yeah. So it has been a great discussion. I think it's already 10:30 and I know everybody's tired. We have just one last question I would like to take, and that's it. I think this is again, Dr. Jinesh. Metastatic pleural effusion and carcinoma lung with malignant effusion behave differently. How would you treat them? I think the principles of treatment remain the same. I don't think we'll have any other thoughts on this by any of the panelists.
I think it depends upon the prognosis. Suppose the metastatic pleural effusion is from a malignancy which can be treated very well. So in this kind of patients, actually the decortication might help the patient, like in the trap lung scenario. But in lung cancer with metastatic pleural effusion, as was discussed, the outcomes are very, very poor. That's what I feel. Recently, we had a patient, similar kind of patient actually.
So that's what. So if your post-surgical morbidity is going to be less, maybe you need to intervene. If your post-surgical, the life expectancy is very low and the morbidity is going to be very high anyways, probably you should not intervene. You can do the basic procedures that you do of pleural aspirations, maybe putting an ICD and attempting a pleurodesis in such patients via dark slurry or betadine or any other bleomycin, such thing. But surgical intervention should be avoided in such patients. Even thoracoscopy should be avoided. So I think with that, I think we should end our talk. It's very late, 10:30, and I would sincerely thank all the panelists for being still here till so late and answering all the questions. Dr. Vishwanath, an excellent talk on cryobiopsy and practical tips you shared. Dr. Nasir, hats off to you, sir. I mean, just looking at the procedures that you do, it's really wow for us. And my extreme panel, Dr. Jayaraman, Dr. Jyoti, and Dr. Amol, you've shared your insights, and it is interesting to know what all can be done when we meet. We have a surgeon, we have a physician, and we are discussing cases. So it helps clear many of our doubts also. So I would like to thank each one of you for being on the panel here. And if you have any closing thoughts, or we will just end the talk.
Thank you, Mehul, for this wonderful, lovely moderation. I learned a lot of things from my teacher, Nasir sir, and Vishwanathan, and Jyoti, and Amol. It's a wonderful experience. Thank you very much, Dr. Amitan ma'am, and the IABs for the wonderful opportunity. Thank you. Enjoyed this session. Really learned a lot. Thank you very much.
Thank you, Dr. Mehul, for hosting this moderating this wonderful session, and I thoroughly enjoyed. And one take-home message from my side: early intervention in grade 3 or class 3 empyema is key to success. And for cryobiopsy, yeah, it is a very important tool, and most of them are doing semi-rigid medical thoracoscopy. So I think we have to explore another options, and we have to explore more and more regarding cryobiopsy. Everybody has cryobiopsy for airway disorders, but in pleural disorders, the role are very less and minimal, but data is very robust and coming out nowadays. So we have to explore more and more things in cryobiopsy, in medical thoracoscopy as well as.
Yes.
Dr. Mehul, it's
Yeah.
always very difficult to handle surgeons, There's a lot of ego clashes and definitive opinions, and surgeons are more aggressive as compared to pulmonologists, but interventional pulmonologists are getting there. But fortunately, we didn't have that kind of bullfighting this evening. You were very balanced in your opinions, in your observations, beautifully moderated, and you gave those very useful concluding remarks. I hope as a surgeon I have not tread on your toes and cons of all my dear the future of India pulmonologists. It is over 30 years of experience and the empathy I have for patients. All of us have empathy. And I think that is what I would finally say: to cure sometimes, to relieve often, always we can comfort. So to cure sometimes, to relieve often, to comfort always. That's the least expensive thing, and we can all do that for the patients. And once again, welcome to BronchoCon Cochin.
Thank you, sir. We'll be there. We will be there.
Thank you.
Thank you very much.
Good night.
Thank you,
Good night.
Mehul,
Thank you, sir. Good
and
night.
thank you, IAB, for this invitation. It was a great session. Thanks. Thank you,
Thank you.
everyone.
Good night, everyone.
Thank you, sir.
Thank
Thank
you,
you.
everyone.
Good night. Good night.
Good
Amol,
night.
Jyoti,
Bye bye,
Jayaraman,
sir.
Mehul.
Thank you.
Bye.
Thank you.
Lovely
Bye,
meeting
sir.
you.
Good night.
Bye, sir.
Take care.
Good night.
Wonderful moderating, Dr. Mehul. We
Thank you.
really enjoyed
Wonderful.
it. Thank you
Thank
so
you.
much.
Super.
Thank you.
Enjoy.
Bye.
Thank you very
Good
much.
night. Good
Thank
night,
you,
guys.
everyone.
Good night.
Okay, good night. Thank you.
Good night, Vishwanath. See you
Bye.
in
Good night.
Cochin. Yeah.